Ready, set, tube. A cross-sectional assessment of readiness for chest tube insertion in my intensive care unit trainees. Usually, I hate reading slides, but I may do it some more this time. Guys, thank you so much to whosoever is listening to this for agreeing to take part in our study. It's a really simple idea where we're just going to watch you do a chest tube and be able to check for which parts you do well, which parts you can work on, and try to decide how best to design a curriculum that will address all of our needs. So we have to kind of just go through the nuts and bolts of putting in a chest tube before I ask you to do one. I think it's pretty clear why patients need chest tubes. They have air or fluid between the lung and the chest wall where it should not be, and a chest tube needs to be used to drain it. I will not belabor this slide. I will belabor the heck out of this one because I think that chest tube success, just like line success, ET tube success, a lot of success in life and in procedures and in medicine is more about the preparation and the positioning than it is about the actual procedure. This could not be more true than it is for chest tubes. Taking the time to do an appropriate risk assessment, to do a timeout, to have consent, the right patient, the right side, the right x-ray, etc. is really important. You're hearing from a guy who has definitely tapped the wrong chest as an intern, believe me. The other things you should think about are to consider pre-medications. Things like narcotic agents, benzodiazepines, even a full brief procedural sedation and anesthetic to make the tube more easy to obtain. Having good access for sure is important. You do not want to ever do a chest tube without an IV first. Find ways to monitor the patient. Have them on oxygen. Have them on a monitor if possible. You need an assistant for sure, and you need to be absolutely sure that all your equipment is set and in the room before you start. Also nice to be sure they're not taking rivaroxaban. That has been a problem in the past as well. So the standard tray you'll get at LHSC looks exactly like this because this is a picture of a standard tray at LHSC. Those important things are a ratcheted instrument like a Kelly, and I'll highlight one just here right now, that you would want to use to clamp onto a tube. You'll clamp the Kelly lengthwise along this end here that has all the holes, point for those noticed, and then as the holes goes in the chest, okay? And this end back here that's cut on a funny bevel attaches to the underwater vacuum assisted seal known usually as a pleurovac, an atrium, or the underwater seal for the chest tube if we're going to be generic. Those are the tools you'll need. There's no blade on it, so bring a blade for yourself. Otherwise, that and a stitch, and you're pretty much ready to start the procedure. Now, positioning is so important. Picking the appropriate insertion site we'll go over again shortly. Consider using ultrasound to guide it. It's a great tool now to find the fluid pocket, find the area you're going after. Using very strict sterile technique is important, and I'm going to emphasize this again. Loads of local, like 2 or 3 milligrams per kilogram of 1% lidocaine is a great idea. Like a bottle or two, 20 or 40 mLs of the stuff is really smart for the average sized person, okay? When it comes to putting the local in, I do want to see people insert local, or if they're fully asleep, your finger in the Kelly, in to hit the rib, slide up above the rib to the superior border, and aspirate and inject the pleural space so you know you're in and you know where to infiltrate the local. This is a really kind of odd pixelated picture, but it shows you the triangle of safety really nicely. The lat in the back, the pec in the front, the nipple line inferiorly. This is a safe place to put it. Now, believe me, you don't get any style points for shoving the tube in up in the axilla. That's silly, okay? And, I tend to put mine right at the nipple level, so the other rule of thumb I like is a hand breadth from the axilla down. That'll usually land marquee somewhere in here. It's a very safe place for a chest tube. Okay, so again, this is just for repetition aids memory, right? The needle goes in, hit the rib, and work up, 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 and over with your needle and your Kelly to avoid these delicate neurovascular bundles. They bleed a lot, okay? And the ideal thing, again, is to make a cut down here and tunnel up and over the rib. That is, I think, for maximum style points. The direct action technique, cut here, bang in there, and get right through, also acceptable, especially in a hurry. So the blunt dissection is something that I think is hard to explain and easy to do. It has to do with making an incision that is, of course, parallel to the ribs, and using a Kelly clamp to push the nose in and spread. Come back a bit, push in again with the tip closed and spread. And it's creeping forward, and creating that tract, okay? Puncture the pleura with a quick pop through, careful and under control, usually putting your finger on the actual bolt of the instrument so you can't pop in too deep, okay? Then guide the chest tube in over your finger after you put your finger in the chest and swept away adhesions and made sure you were free of all impediments. Don't push too hard, and make sure all the holes get into the pleural cavity. The numbers on a chest tube, like 10, 12, 14, that's the number of centimeters from the last hole. You want at least 10 on the average person, more like 14 for our heavier set trauma guys, okay? Attach the tube to a drain carefully and sew it in place to make sure it's not going to pop out. And confirm location by clinical signs like swinging fluid in the chest tube and fluid drainage, as well as by an x-ray, okay? A little quick shot here where the cut goes and how it's parallel to the ribs. And then this is just that stepwise approach of A is local above the rib, B for the incision, C is that push and spread to make space, D is your finger pops in and confirms pleural placement, E is how you change your finger out for the Kelly. You see the Kelly grabbing the tube lengthwise there, pops in, and F's the tube being threaded as best you can posteriorly and superiorly. Okay. In terms of sewing in place, use a stout, heavy-duty non-absorbable suture like silk or proline. Secure it with an anchoring stitch that is tight on the tube, but of course doesn't collapse it or compromise the tube's sort of inner lumen. Connect the drain, put a good solid dressing on, and secure it to the skin with tape. Okay. We like to tape or actually use the zip tie gun to keep the connections of the chest tube to the various tubing in the circuit to the pleural drain secure, and of course get an x-ray to confirm placement. This would be a unusual drawing, but acceptably showing a nice purse string and a nice sort of multi-wrapped around, multi-knotted way to hold this cat's cradle-like stitch to the chest tube. I don't really care how you do it, but do it well, do it tight, do lots of loops and lots of knots, because a pulled-out chest tube is basically worse than no chest tube at all. Okay, this is a good example of a dressing. So you see the purse string chest tube, a dressing there that can go over top of the site. And here's an example of a chest tube that's in what looks like good position, although I notice the lung is still quite thoroughly down, so presumably it's just not on suction yet, or I guess worst case scenario, this could be behind the chest cavity, not in, but that does have the appearance of a chest tube that should be working, so check back in with him later, okay? That's it for my Get You Ready talk, guys. I hope that was sensible, and I hope you're ready to go ahead and show us your skills at popping in these chest tubes. Thanks very much. Just one more thing, kind of Columbo style. If you do feel like you want to see a real live chest tube fly in, there's a great video put out by one of actually Sandra Rizzoli's fellows, who is now a staff guy, I think, in Toronto. Bartolo, whose name I won't try to pronounce, Nascimento there did it. It's done through the New England Journal site, I think, out of Sunnybrook, and it is a very nice video to watch, and if you'd like to watch it, it is available for you prior to going in with the study. Alright, great. That's all we have.